I'm delighted to have a chance to introduce Ginger McKay, Dr. Ginger McKay, who's an assistant professor at the Brown School at Washington University in St. Louis, where she is also the assistant director of research for the Center for Public Health Systems Science. She holds an MA in Medical Anthropology and a PhD in public health, and she completed her postdoctoral work at Washington University, where she has built her implementation science research program. Ginger is going to be sharing findings from her current research on antibiotic use in children's hospitals. And I understand that the data is hot off the press. So some of what we're hearing, we'll be the first folks to hear this. And she will also engage us in a discussion about building implementation science through sharing efforts that have been successful at her home institution. So it's particularly exciting to introduce a graduate of our program, Ginger McKay.
Thanks for that stellar introduction. And thank you for having me. I am taking all the credit for the excellent weather that we're having. So I think that's good. I'm going to talk a little bit today about a project in a research trajectory that I've been working on for some time now. And the seeds of it were sown in my doctorate and really escalated when I started my postdoc in Washington University in St. Louis, focusing on excessive antibiotic use in pediatric hospitals. So I'll, if you're not that familiar with antibiotic use in pediatric hospitals, I'll get you oriented to that. Talk about our approach to addressing this problem using implementation science through a trial that we call affectionately the operatic trial. And then, we were discussing these results yesterday as a team with our first look at it. So I'm excited to share them. They're good. So I'm excited to share them with you. And this is our team. It's truly a transdisciplinary team. We have infectious disease specialists, surgeons, implementation scientists, and data analysts. And it really has taken all of us to do this project and make it a success. And this work has been supported first by a pilot award that was internal to WashU through the Center for Dissemination and Implementation, and then subsequently by an R01 supported by the Agency for Healthcare Research and Quality. Okay, if you didn't know, excessive antibiotic use out in the community, but also in hospitals, is a very problematic issue and a growing public health concern. And for a couple of different reasons. First, to the individual who is excessively taking antibiotics, it increases the risk of something called C. diff, which is a very unpleasant stomach problem, and you can actually die from it if you don't get it treated appropriately. But then also to the public at large, because with excessive antibiotic use, it increases the likelihood of multi-drug resistant organism emergence, and then subsequently reduces the likelihood that those antibiotics remain effective. So within hospitals, it has become the standard within the U.S. to have teams of people whose job it is to monitor and optimize antibiotic use. We call them antimicrobial stewardship teams. They typically consist of infectious disease specialists and pharmacists, and then occasionally you'll have other people getting engaged. And within pediatric settings where I have been working and my colleagues work, it has been well demonstrated that the majority of excessive antibiotic use is happening after surgeries. And so I didn't realize this before working with them, but most children are coming into the hospital for surgery, unlike adult hospitals where you might be in there for any number of reasons. And so, and while it is appropriate to give antibiotics to kids prior to surgery, in order to prevent a potential surgical site infection, those antibiotics are no longer needed after surgery for many, many types of surgeries. If there's a clinician in the room, we call them clean and clean contaminated cases. Okay. And I'll add that there are many, many guidelines that recommend that these antibiotics are not needed, but we know that approximately 40% of the time, children are getting these antibiotics they don't need, and it accounts for about 17 to 18% of excessive antibiotic use in the hospital at large. Okay, so simultaneously within implementation science, there is growing interest in what I like to call misimplementation. It's an idea put forth by Ross Brownson, which really focuses on optimizing intervention use past the adoption and implementation stage. So sustainment and making sure that those interventions stay in place when we want them to be there, or if the evidence is poor, that we make sure that those things get yanked. And this is where I really love this stuff and really enjoy it. And it is of growing interest within our field. And the reasons are because, like with antibiotics, it can cause harm to individuals. It leads to wasted resources that can sometimes be very precious. Sometimes it's necessary because the evidence for particular interventions changes. And sometimes issues get resolved. Yet we know that many, many interventions continue when they should actually be stopped. There we go. I can use this. Within my field, there's been a lot happening over on this far right corner, conceptualizing, understanding the extent of the problem, how often and when these phenomenon occur, a little bit in trying to understand what drives keeping things in place when they should be removed, and whether that is helping or hurting. And then, but we have very, very little evidence for what are the best approaches or strategies to helping get those things out. So me and my colleagues have this natural alignment where I have an interest in figuring out what removes successfully things that shouldn't be there. And then they have this major looming public health crisis from excessive antibiotic use and trying to get people to stop using them. So initially, as a postdoc, I did some pilot work with my colleagues to just understand why are people doing this? And so we conducted a series of focus groups with surgical subspecialties. And from those focus groups, 5 themes emerged. One being reliance on prior experience. They sort of learned on the fly in their training and never received any update after that. Sometimes years and decades later, still doing the same thing. That there's a sense of wanting to balance the risk of infection versus the risk of a bad outcome from excessive antibiotic use, and being really concerned about surgical site infections. Some skepticism about the evidence, and this becomes really critical, poor communication and collaboration between stewardship teams and the surgeons themselves. They do not like them. They often describe them as like the police trying to catch you doing something wrong. And then some larger hospital level concerns of, do we have support for this? Do we actually know what's going on? Is this really an issue at our hospital if we can't measure it? That sort of thing. So based on these results, we began a trial supported by AHRQ, the operatic trial, with the goal to eliminate unnecessary post-operative surgical prophylaxis. We designed this study around a theoretical model called IPARIS, which what's really useful about this particular model is that it conceptualizes a person that they call a facilitator who is responsible for making change within a system. In our case, it's stewardship teams, and they affect change by taking into consideration the context. So in this case, the hospital, the evidence itself. So in this case, antibiotic use, and then the people who will be using that evidence, so surgeons. And that by affecting change on these three domains, that it leads to better evidence-aligned practice. So we and stewards are our ideal facilitators and in hospitals because they're very knowledgeable about the evidence related to antibiotics, and it is their job to get it implemented in the hospital. So we thought that it would be most effective to intervene with them, and recognizing that they often don't work well with the people with whom they're trying to affect change. And we are testing 2 implementation strategies that they are then supposed to do in the hospital. The first being order set changes, and then the second one using facilitation skills. And I'll talk about those a little bit more next in the next couple of slides. We enrolled 9 hospitals in our trial, geographically dispersed around the country. We leveraged a stepped wedge cluster randomized controlled trial. So we randomized each hospital into a different cluster, and then depending on which cluster you're in, you are stepped into the intervention arm of the trial. So everybody starts out in the baseline arm, and then you can see the step. People gradually move over into intervention. We did spend some important things to keep in mind. We did spend 1.5 years sort of in strategy development. COVID happened about right here. We were supposed to do all of this workshop and training and stuff in person. That did not happen. And it ended up being somewhat fortuitous anyway. And we enrolled participants from each hospital who were part of stewardship teams, ultimately about 30-ish, 38. And then we collected data from them either every 2 or 6 months, depending on the measure that we used. And we collected information on perceptions of the strategies and their usage, implementation outcomes. So do people successfully manage to reduce antibiotics or not? And then clinical outcomes through an existing data collection effort that is tracking antibiotic use and surgical site infections. It's called NewsQuip. It's done by the American College of Surgeons. And we are talking about how to, because we're right here, and just this morning I saw that we have completed our data collection. So I'm feeling really good about it. Okay, so to tell you a little more about our strategies, you'll notice we don't have a traditional control arm where we're not intervening with them. And the rationale for that is because we know as implementation scientists that if you don't do anything, nothing is going to change, basically. So we made the case that it was best to have a more low touch intervention compared with a more intense intervention, and compare those two. So the first one is order set changes. The reason we picked this is because it has a lot of benefits up here, and it's really what surgeons use to guide their clinical behaviors outside of the surgery itself. So any sort of additional procedures that they want the nurses to do, standing orders for medications, it's all contained in that order set. And so by changing it, you are effectively creating structural and sustainable changes. And then facilitation, because of the position of stewards, and there is good evidence that it is effective, but it's a little bit of a squishy idea that has a growing amount of evidence, and there's a couple of dimensions to facilitation that are showing to be important. So we define it as an active mechanism by which a person is responsible for implementing evidence. And so I think it's easier to think about, well, what makes a good facilitator? And these are the evidence-based skills that most good facilitators have, with a key one being good communication skills. So that, as you'll see, or from our prior work, starting to line up of how, like, what is the right approach to address this problem of poor communication between stewards and surgeons so that they can get the surgeons to do what they want them to do. We set up a workshop to help them with this. 4 weeks, 2 hours, which is actually kind of a lot of time with clinicians, attendees from each site. And each week, we broke it up into specific pieces. You'll notice that these pretty much align with the iPrayers framework and what you should be focusing on via that model. Some more detailed things that we covered, because this will come up in the results. But I think in particular, things that I want you to take away from this slide is understanding the evidence that we actually talked with them about, not only like national guidelines, but how to look at the evidence in their own hospital, because sometimes you make different recommendations based on what bug is floating around your hospital at that moment. And also the perceptions and feelings of surgeons, and what is driving their behavior. And that was like mind-blowing to them, that surgeons would have all of these concerns about risk and anxiety, and that they haven't been educated anytime recently. And so they found that really interesting. And then another key piece of this is we spend time with them. My clinical colleague likes to call this the squishy stuff. How do you have effective communication with people, especially when you're in the midst of a conflict? And how do you negotiate that? And then techniques for communicating evidence. So it's not often, as we probably all know in this room, for the evidence to just be there. You have to communicate it in a way that is tailored to your audience, that they can understand it, that they want to look at your slide, and take all of that in. Okay, where am I at? Okay, so just so you can see a little bit about who is reflected in this study, with the stewardship teams, it's heavily physicians and pharmacists, few other people. When asked how they feel, they would rate themselves as facilitators, either beginner or like some experience, that nobody felt very good at that. In particular, some of the patient characteristics reflected the NSQIP data that we have been collecting from folks, fairly balanced male and female, and then a wide variety of races. But I do think this part is the exciting part, is that a huge number of cases and patients that we are trying to impact. So when asking people how they felt about the workshop itself, people were generally very positive about it. They really liked being it. They didn't mind the length so much, although we do believe that we could probably shorten it down some to make it more palatable for most people. And you'll notice that we asked, what do you think you'll use or not use? And people were very positive about most things. I would say least enthusiastic about presenting evidence, so data visualization and NSQIP data presentation. So here, this next slide is where we were having a lively discussion yesterday. We asked routinely about people's feelings, perceptions about whether they could do the changes we're asking them to do, and whether those are good strategies from their perspective. So up here we have a set of measures based on the COM-B model, if you're familiar with that, which is supposed to conceptualize all the things that you need leading up to behavior change. And then a series of implementation outcomes reflecting both order sets and facilitation, and how people perceive those strategies as either like acceptable, like that's a good approach, appropriate, like that's the right approach, or feasible, yes, I can do this, or no, I can't. And I have left out all the in-between steps, and we just have baseline and post-facilitation. And what's interesting about this is that in all likelihood, even if we run a statistical test on this, it will not be significant. And why that is the case is why there wasn't much change pre and post intervention was very much the subject of discussion yesterday. And one, we think maybe there's a ceiling effect here, that everybody, this is on a Likert scale from 1 to 5, that there's a ceiling effect and everybody felt very capable, like they had an opportunity, that they were motivated to do it, and that the strategies similarly, they were acceptable, appropriate, and feasible. I think on a positive note, that it also means that people liked these strategies, like they felt okay about trying to do them. So even from the beginning, and I wonder if maybe that we talked about doing a member checking thing with this data. Even from the beginning, they felt okay with it. So there just, again, wasn't much room for improvement there. Okay. What skills do people use over the long term? This is sort of aggregating all those collection points together. And people said, even when they said no initially, when they were probed a little bit, they actually, I shouldn't do that. They actually said, yes, we did do facilitation skills. We used skills from that workshop. Many instances of using team building techniques, so engaging people to work together on a common problem, and conflict and communication skills, and then not as much with data visualization and presenting evidence. And I think an interesting way to look at this as well is like what happened in one single site. I'm a big fan of cases. So you'll see this aggregates what was reported at a single site, and you'll see that different skills were used at different times over time. So in the beginning, and I'm actually excited about this, people did context assessments, which is good. We want them to understand what the barriers are in their context, and then work with people to resolve those issues, and then check in to make sure that those barriers that they identified in the beginning have actually been addressed. So this is really fascinating to me. And then we did ask people routinely every 2 months, did they actually make changes to order sets? We found that they actually did. And I think in hindsight, well, maybe in the future we will do this differently. They were really allowed to target any procedure, target any department that they wanted to do. So they had 82 instances of attempting to change any kind of order set, sometimes develop new ones, sometimes revise existing ones, and they were successful 68% of the time. Different sites had varying success. One of our sites only got one successfully implemented. Others were very, very successful. And because we didn't give them specific direction, they targeted different departments. So neurosurgery, general surgery, and orthopedics were among the most commonly targeted. And varied de-implementation outcomes. We also didn't specify exactly how the order set should be changed, other than it should be optimized. So that looked different by order set. Sometimes they successfully reduced the number of days antibiotics were being given. Sometimes they were able to eliminate them completely. Sometimes they were able to narrow the number of surgeries eligible for prophylaxis. And then sometimes they were able to change the kind of antibiotic that was being used from an inappropriate one to a more appropriate one. So a lot of different things. People did a lot of different things. And what another piece that we're excited about is that only 5 of these 56 order sets were accomplished prior to our workshop. So that is very positive indication of the success of our workshop. In promoting change, you have to be a little bit careful with that interpretation, just because sometimes it takes a while to get these things changed, and we haven't had a chance to really dig into, like, if something was started and then they did a workshop and then it was finished after the workshop. Are there many instances of that? But even if there are a handful, this is still very, very positive for us. And then the other interesting thing that I did not expect at all when we started this trial is that people would also, in addition to order sets, decide to do other things that they felt were like good interventions and strategies in their situation. So having informal agreement, sort of like a handshake agreement with departments or surgeons to reduce antibiotics, implementing guidelines, our new guidelines, which is very difficult to do actually in clinical settings. Better ways to understand the evidence and the data for their hospital, doing educational interventions, all kinds of stuff. So we feel like we have been successful in our implementation outcomes, and our clinical outcomes are also seeming very positive. So we know that 4 out of the 9 hospitals targeted spinal surgeries specifically. So using the NSQIP data, we were able to examine pre and post facilitation and appropriate antibiotic use for those surgeries specifically. And we're estimating that there's a 3 to 4% decrease from pre to post facilitation. And given the the numbers, we feel like it's likely sufficiently powered to be a significant difference. And in addition, I would say that that is a conservative estimate of the impact that we think that we're having in our setting, because remember that we're comparing one intervention to an additional intervention. And so we think using the 40% estimate as what most people are experiencing without any intervention at all, we actually think that we're bringing it down closer to 7 or 8%, which in a hospital for any particular department, that's actually a lot of change to make. So some early conclusions: virtual facilitation is doable and even preferable. It allowed us to bring hospitals together, and they seem to really like that. Stewardship teams liked our training, and clinicians can use these strategies to accomplish their outcomes, and that's really promising. And we think that it is, in fact, yielding meaningful benefit for patients and the public at large. We have more analyses to do, very clearly. And I was hoping that we would know the answer to this by now, but we are prepping for scale-up via an R18 that we submitted last year that has been scored within a fundable range. And so we're hoping that will come through in the next couple of months. And for that particular study, we think we can improve the workshop, that we would open it up to any hospital, any pediatric hospital that was interested in taking it. Probably provide some more targeted guidance on which procedures or departments to address, which will hopefully also make our evaluation a little bit easier. But however, continuing to evaluate the outcomes and the impact of our work. Okay. Thank you. So much. Sure. Questions?
I had a couple of questions. Can you speak more about the process you use to partner with these hospitals to do this? And also, I was curious about the misuse or the successful post-facilitation changes. Were they more in situations of a post-op follow-up, or was it like a PICU, ICU setting and inward, like inside the hospital setting, or was it like after discharge, or when was the misuse happening?
Like in the ICU, like immediately after, immediate post-op, in the hospital still. And then to your other question about how did we work with hospitals, I have the pleasure of a colleague who, and working with him, who is a pediatric steward, who is very much a leader, and he has helped create the collaboratives with the different hospitals.
I also have a couple of questions.
Sure.
First, you talked about basically changing the way the clinicians operate,
Yes.
as opposed to changing potential patient outcomes. Do you have any kind of results on patient outcomes in the various arms of the study?
So, not yet. With the key ones being surgical site infections and C. diff infections. And starting today, I guess, we can start to unpack that a little bit. But, and we're hopeful, the key thing that we would like to see is even with reduced antibiotic use, no increase in either surgical site infections or C. diff. well, actually, perhaps a reduction in C. diff infections.
And my other question, doctors have a lot of motivations, one of which is pressure from parents.
Sure.
That show up anywhere in your study?
You know, it did not. I think that that's actually a really good question. And if we were in like a pediatric clinic out, I would say that I would think that would probably be true. But when we're in an inpatient setting, my suspicion is that parents are more they're just with a surgery happening, they're not concerned about the antibiotics, and so they aren't advocating one way or the other about them.
Given what's going on the internet, you can't be sure of that.
Yes, but it also did not come up in our pilot work. So, when there was ample opportunity for that to emerge.
Have you thought about doing any kind of economic evaluation work with this, just given
Yes.
how effective and cheap your implementation really is?
Yes. And it's a little bit easier said than done. Just because, like, are you a clinician?
I'm an athletic trainer, but
Okay.
on the health policy side.
Okay. So if you look at what I didn't show is, in addition to targeting different procedures and having different outcomes, they also targeted different drugs, different antibiotics. And so, and I have been trying to figure out, like, how would we do this? Each drug is a different price. It's, and the prices vary from hospital to hospital. But that is a common, talking about motivations, is a common motivation for at hospitals if there's cost savings from antibiotic reduction. So
Trying to find one cost measurement in the American healthcare system, pretty difficult.
it's hard. I wonder, and my thought is, I wonder if we could pick maybe like the most expensive thing and price that out. Yeah.
Did you have any, maybe you did, and I missed this, process measures when we're looking at kind of, learning, how much folks learned over the sessions, sort of from pre to post, deal with the argument that, well, they already knew most of this stuff. It was just reinforcing what they already knew. Not that that was probably the case, but.
Not in the way that you were talking about. Pre and post training is what you're talking about.
Did you do that now that you've done the pilot study and the bigger study and develop some structure?
We could.
Questions, yeah.
We could do some pre and post measurement of the
And you know,
drugs
everything
and stuff. Yes.
Early days, but I was wondering if you had thought about like sustainability, like additional training or coaching opportunities.
Yeah. Well, beyond, I would say we're just gearing up for the next 5 years, and we have done some things even for the next 5 years and trying to scale it up with like the same size team. How to bring it up to scale, which isn't exactly a sustainability, but they're often intimately tied. And so things like something I'm excited about with this next study is we're going to be able to offer continuing education credit for people to come to it, which is like an easy, I don't know why people don't do this more often, but an easy incentive to bring them in, and I wonder if there's some sustainability potential there as well. For like a small fee, you can get your students.
Going back to the table where you said you had a robust discussion the other day about your pre and post test results.
This one.
Yeah. Did you talk about response shift bias?
Yes. As well.
as well as a possible explanation. Well, and we're talking about like your number of people is 30, right?
Yeah, it's small.
Small.
The first one is 38. Sometimes there's different numbers at different steps, but
I guess I'm just curious more about that conversation, and I'm thinking about the measurement options, if this is important to you.
well, yes, we also wondered about the validity in the measures. I have a question. I sort of am suspicious of that a little bit as well. Do you mean like desired?
I mean, well, yeah, and just like the scale, like using a scale, it's a pretty blunt instrument with 30 people, and
yeah,
like
that's
you use a slider. Yeah.
Thank you. Yeah, and so basically where we landed is that we want to show these data to the participants because, like you're saying, it's a small group. We know them fairly well.
But the scores were high,
Yeah, they were high.
the pretest.
Yes. And see what their suggestion might be as well.
Are there any questions online? Where there is one that's popped out. Okay, good and outright. But from Allison Myers. Ginger, thank you for being here. Like Allison. I'm curious about other settings, topics, or about issues of interest that you're working on, or research questions you've been helping to involve. What are your seeing of ideas, interests, why?
An enormous question. Okay. And that's a really monster question. Okay. So when I graduated from here, I was really in de-implementation and HIV. So I worked really hard to expand beyond HIV and do implementation science in other areas of infectious disease, which I find I actually really enjoy. And I think there is so much potential there. Other areas of de-implementation, like I said, this is still considered a very new part of what is truly a very new field. And so I think that you could throw a rock into a new idea as it relates to de-implementation. I have a love of systems science and systems thinking, and I am forever working to try to integrate that into my work and have done that with like mixed success. But really, in a lot of ways, the sky's the limit. With stewardship in particular, I think there's also, I didn't say this, but so you're in an inpatient setting, you're required to have a team, and they suggest what you should be doing in terms of strategies to optimize antibiotic use. But there's the evidence supporting any of those strategies is actually very poor. And I hope to build that up some so that people can use their time well and not be spinning their wheels doing stuff that they actually don't need to be doing.
So I'm wondering if I could tag on to the question with opening up the discussion to talk.
Right.
Most of you don't know Washington University. It is in platform both public health and dissemination implementation science. They've been leaders in long areas, and Ginger has been there for
7 years.
7 years, I was going to say almost a decade. And I would like to hear a little bit either questions or discussions of what are some of the things that are happening there that have helped build this area, and what kinds of opportunities might a place like you think about well-means into place to so either questions from the group in that area, or you want to just
volunteer some things. Yeah. I didn't want to, I see your hand up. Is it about the project or about implementation?
About the project.
How about, I'll take that after when we're done, if you don't mind.
I'll have another meeting after this, but go ahead.
Okay. Sorry. Okay. So I think one parallel between WashU and here is being part of a CTSA. At WashU, we have a core within the CTSA dedicated to dissemination and implementation science. I'm part of that core myself. I have been doing it for some time. And so what I do in my job is I actually provide consultations to people about DNI in their respective field. And I've worked with like a lot of different types of people on a lot of different types of projects, just serving as a card-carrying implementation scientist. And that has helped, I'll say, me personally as an early career person, because I was allowed to work with people, like I was paid to help them develop proposals and build implementation science into their projects that then, once they were funded, I was written into those grants. And then also it helps create exposure with other investigators, mostly clinical investigators, but some public health as well, to DNI. And sometimes they really get the bug, and then they're all the way in it. And I have seen many of them, like my time with them, sunsets, and then they go off and do more DNI stuff. And that's been very rewarding, honestly. Another thing I mentioned earlier, I don't know what the capacity is for this here, but we have quite a few pilot mechanisms for generating pilot data, and some of them dedicated specifically to DNI research. And it has helped seed larger projects. The return on investment for many of those has been very, very good. That people come away from those pilot grants and are able to apply for R01s. This project is one of those projects, and successfully secure them. And in this case, we think another one. So that $30,000 investment has been very good. $30,000.
What was the time frame between the pilot and the AHRQ?
It was maybe a year. Well, from the end of the pilot to the next. Okay. Well, it felt like a long time. But really possible. Yeah. Those are the two like obvious ones that come to mind. I came in as a postdoc. We have really good postdoc programs for people interested in DNI. We're starting to offer degrees that specialize in DNI. That is out there as well.
Let's talk a little bit about that.
That is a brand new this degree. That is a brand new thing that we are starting to offer. Although I think that there are multiple institutions that offer some sort of specialization where we're going to get.
Yeah, but I'm just curious to know if I could start. Is it the doctoral level?
At the doctoral level is what we are doing, with the hope that people come away with specialized in particular methodological expertise relevant to DNI, and then are working in their respective content areas.
What about those else? Did they join our
There are T32s. That's how I came on. And then on there are some project-specific ones as well. And I can see how the project-specific ones might be more feasible here than a T32. Maybe. That's not shade. But then those students have also gone on to be very successful as well.
Other bigger questions?
Hi, Molly.
Sorry.
Oh, thanks. And thanks, Ginger. I'm sorry, I missed kind of the first part of your talk, but I was just kind of curious what your perceptions are, because with regards to how you have been working in clinical settings and have the expertise there.
Mm-hmm.
And one of the things that we have here at OSU is extension, in particular, like family, community health, extension service agents and things like that.
Mm-hmm.
And what your perceptions are about similarities or differences with regards to trying to use your kind of study design.
Sure. So I work with lots of clinicians, but I'm in a school of social work. And DNI has its origins really in social work and mental health, out in the world. And so there is tremendous, maybe that's hyperbole, there's more acceptance of studies designs that balance internal and external validity a little more equitably than like is common in clinical settings where double-blind randomized controlled trials are the gold standard. And so it is, if you dig into the literature, especially the mental health literature, there are lots of, there's still randomized trials, but clustering at some kind of level, like the school level or clinical practice level, or perhaps the family level as well. Does that help?
Mm-hmm. I'm conscious of the time, and I think what I'd like to do, is there one more burning question?
Oh,
No. Well, I realized one thing. Well, so the hospitals, did you end up in the sub-awards with them, or do you find it with hospitals it's like fees for services? And I noticed that they offer breakout, but in your case, you weren't doing service. You're probably
we did use it.
You did use it. Okay, that was one on your one in your.
Are you a REDCap person?
We just started it.
Okay.
Yeah, we just started it, and there's certain costs, but like I noticed at WashU, they're offering it for free. And
they do. It's an institutional resource, and it's heavily incentivized because our IRB, if you don't use REDCap, our IRB requires a lot more from you. And that is very much a lot of people. Because it offers, protections for personal health information and personally identifying. And we provided an incentive to hospitals. So just like each year that they participated, a check.
Okay.
that's so my postdoc mentor, Anola, that is her background. Yeah.
And some of the other leaders in the field.
And many other leaders. Byron Powell is also, his degree is in
Some of those folks. Yeah.
Mark McGovern is another one. Lisa Saldana, who's local psychologist. Yeah, but she's mental health.
Mental health. Okay. Yeah. But you're right. Yeah. I want to thank everybody for coming.